The PRESTIGE trial is a physician-initiated, prospective, non-randomized, single-center trial investigating the safety and efficacy of the treatment using SELUTION Sirolimus-Coated Balloon in TASC and D tibial occlusive lesions in the setting of chronic limb-threatening ischemia from Singapore. The balloon in question is SELUTION from MedAlliance, and basically this uses micro reservoir technology to form sirolimus polymers to basically get it into the arterial wall using cell adherent technology. The primary objective of this study was to evaluate the 6-month safety and performance outcome of this balloon, of which we recently reported this in JET. We want to look at treatment of long tibial occlusive lesions in the setting of CLTI, and we will summarize the 12-month data which was presented at LINC and report new data of the 18 months follow-up. These were the PRESTIGE endpoints of interest, the usual of typical registry data of lower limb angioplasty work. The study site of question was Singapore General Hospital, and from 2 experienced endovascular surgeons. Enrollment was over a 3-month period. We screened 71 patients, 27 were eligible, but 25 patients were enrolled, meeting the angiographic inclusion criteria. 18 months was followed up and was completed for 19 patients in July 2021, with 4 deaths and 1 below-knee amputation. 1 patient was lost to follow-up. These were the inclusion criteria of interest. We included de novo as well as restenotic lesions in the tibial vessels. We used long lesions, more than 10 centimeters of TASC or D lesion types. The stenosis had to be more than 50% or occlusion. We had to traverse the lesion first up. Vessel diameter size was between 1.5 to 4.5 millimeters because of the balloons available. So there must have been some distal reconstitution above the ankle, and we had to treat the inflow vessels appropriately before we dealt with the BTK lesions. This is the flow diagram. The exclusion criteria were quite few, actually relating more to real world registry data and what we deal with every day in Singapore. So we looked at 18 months data, and although this did not include duplex data as part of the protocol, we did follow this up with quality of life as well as walking impairment questionnaires. Turning to patient demographics, these are the patient demographics of interest. And I think it's important to appreciate that this is a frail population. The majority were diabetics, almost in 90%, with a significant number, almost 45%, with end-stage renal failure and established on hemodialysis. All were R5 lesions of patients, and over 50% were moderate to high risk on the WIFI score for major amputations. Turning to the characteristics of the operations, importantly, there were no bailout stentings from this procedure. The majority of vessels treated was the anterior tibial artery. Obviously, split almost equally between TASC and TASC-D lesions. And over nearly 2/3 of these patients had lesions with moderate to severe calcification. Just to remind you, at 6 months, we had technical success of 100%, freedom from device and procedure-related mortality through 30 days of 100%, freedom from TLR of nearly 93%, an admirable amputation-free survival at 84%, a primary patency rate as defined by duplex of nearly 82%, and a wound healing rate of 82% as well. At 12 months, these results were very sustained. Again, freedom from TLR was nearly 93%, amputation-free for survival 84%, primary patency rate of nearly 78%, and the wound healing rate was sustained around 82%. Now, this is the slide of interest for this talk. You can see that at 18 months, Freedom from TLR again was very good, nearly 88%, and amputation-free survival of nearly 80%, with only 4 deaths and 1 BKA, and the wound healing was sustained around 80%. Importantly, there was some progression of disease, with 3 subjects developing symptoms on the contralateral front limb, of which 2 of them required major lower limb amputation. 2 subjects had recurrent symptoms on the ipsilateral leg, of which 1 of them required a forefoot amputation, and 1 patient was lost to follow-up. In summary, you can see the sustained results using this balloon through from 6 months almost to 18 months. In terms of success, mean Rutherford score improved from 5 to normal 1 at 6 months, and pretty much was sustained at 18 months, albeit with some deterioration. There was at least nearly 79% of patients showing improvement by at least 1 Rutherford score from baseline to 18 months. And you can see from the quality of life questionnaires, they were pretty much sustained using the EQ5D VAS scores, both at 6, 12, and 18 months. And looking at the walking impediment questionnaire, sustained between baseline, improvement between baseline and 6 months. And you can see there's a slight drop off, but probably required because of progression of disease and intervention for contralateral problems. So in conclusion, ladies and gentlemen, the experience using solution balloon from SGH in Singapore is positive. It is a safe device with no serious adverse events using the balloon catheter through to 18 months. The 18 months data is encouraging. There seems to be a sustained effect both clinically and angiographically. The quality of life measures are generally maintained. Recent concerns from the Katsanos meta-analysis with higher major lower amputations in using paclitaxel devices is now become quite relevant. What we've found with this balloon, and I think it's important to report, is that there is minimal slow flow phenomena, especially if you treat below the inframalleolar region. 2 years data will be available in January 2022. Just going on to quickly, just to give you a flavor, the slow flow phenomenon that we did not find with this balloon. Obviously, there's a concern about distal embolization of drug using paclitaxel balloons. Obviously, in the cardiology setting, this is a big primary concern, and obviously one of the issues of why they shifted away from paclitaxel to sirolimus. In the CLTI setting, this becomes much more relevant with poor outflow vessels in general. What have we learned from this study, albeit small registry? The flow using sirolimus is definitely much improved, much better than with paclitaxel. We've used iFlow data using the 2 balloons subsequently, both after PCB use as compared to SCB use. And what we did was we looked at time for contrast to reach a certain point below the lesion, and definitely was slower in the PCB group. And this is an example of a patient treated with solution, the 3 slides showing the anterior tibial artery lesion that was treated subsequently with POBAR. You can see the flow is improved with the higher green intensity, and this is actually maintained after solution elution. If you compare this to an SFA that was treated with a high-dose paclitaxel balloon, you can see the flow is generally much slower, with the blue showing a slower flow, and very similar to what it was pre-POBAR. So is solution the solution? I think I leave you with this quote from Bill Gates. I was lucky to be in the right place at the right time. Perhaps this balloon is in the right time, in the right place, especially with the data suggesting that paclitaxel balloons are associated with higher major amputation. Thank you very much for listening.